It's always been my belief that staff working in health services are constantly working on improvement and are continuous improvers, although they may not see that or think that they are improvers. For example, a simple change to the format of a patient handover may facilitate better information flow, incorporate more of the patient's voice and thoughts, and reduce the number of phone calls that clinical staff have to make. What an impact this simple change has made, but it is often not termed as a process or quality improvement. This is what we in the Magdalene Academy like to call improvement on the move, and it happens daily in healthcare services internationally. For more complex improvement, that is projects and systems based, we use methodological frameworks such as the Model for Improvement, Lean, Six Sigma, and a combination of Lean and Six Sigma. Although the Academy facilitated process and quality improvement initiatives that achieved significant improvements in patient outcomes, we discerned that something was missing. We perceived that although the intervention of Lean Six Sigma was showing very impressive results in quality improvement projects and in patient outcomes, a more human factor was missing. We continued to work on Lean Six Sigma improvement, and we began to think about what was this missing factor. And so we began to ask the question, what is person-centered improvement? What does it look like? And how does it work in practice? I knew from my own experiences of care that everyone has their own idea of what person-centered looks like. For example, for me, I would say it's encapsulated in my experiences when my mother passed away. And although a nurse rushed to her side and attended to her, a nurse came to me and held me and hugged me when I was at my most vulnerable. So for me, that was an example of person-centeredness in practice. So again, I asked myself, how did my own and others' experiences and interpretations of person-centeredness and person-centered care relate to improvement? In early 2014, having spoken on my experiences on the use of Lean Six Sigma in healthcare at a conference in Galway, I heard the late Professor Jan Dewing's keynote address on the concepts of person-centeredness, person-centered care, and person-centered cultures. And it was at this stage I had the Eureka moment as I realised that the development of person-centered care and person-centered cultures moves the focus from healthcare staff's technical competencies in improvement methodologies such as Lean Six Sigma to a focus on developing humanistic, helpful relationships. An important lesson for me at this point, and I would say for all of us still, is that a failure to understand the differences and relationship between person-centeredness, person-centered care, and person-centered cultures can result in improvement initiatives that rely exclusively on volume-based measurements and metrics and may fail to take account of authentic patient and staff experiences of care. I realised that developing this understanding, therefore, had huge implications for improvement theory, research, education, policy, and indeed our practice. So central to this research and work was to understand how the use of both Lean Six Sigma and person-centeredness together might facilitate improvements, not only in patient outcomes, but also on patients' and employees' experiences of care, in essence, person-centered improvement. The initial research was undertaken by a PhD and used what we call the critical realist framework to understand what about Lean Six Sigma education and training interventions contributed to specific anticipated outcomes, who they worked for, whether it was patients or staff, and how they were enabled. Within a 13-month review of literature, we were able to identify 4 synergies and 3 divergences between Lean Six Sigma and person-centeredness, with one factor, quality, influencing both methodologies. We then undertook a fieldwork realist evaluation, exploring what about Lean worked or didn't work in research participants' practice areas and why. We were then able to align our findings of the evaluation in the field to the person-centered synergies, influence, and divergences we found in the literature review. This enabled an understanding of what person-centered improvement looked like in theory and practice, and facilitated the development of the person-centered Lean Six Sigma model over a 7-year period from the initial inception as a PhD study to deployment and further testing across 12 clinical sites, both acute hospital and community sector, in both public and private settings in Ireland. Prior to this work, little research was found on the complexities of introducing Lean Six Sigma into healthcare contexts in which the use of person-centered approaches is increasing. The application of the person-centered Lean Six Sigma model has allowed everyone involved in the process of care to play an active role in project delivery. It has facilitated authentic engagement between those involved in change. The model has been developed into a guide designed for staff working within the health system who are using Lean Six Sigma methodologies for their process and quality improvement work, but who wish to take a more person person-centered approach to improvement initiatives. The model is intended to be used as a lens through which individuals and teams can view their Lean Six Sigma work, guiding them to locate their work within a person-centered framework and enabling an understanding of the synergies and divergences between both approaches. We sincerely hope that Lean Six Sigma and person-centered practitioners involved in improvement initiatives find this model of use.